paediatric cardiologist from Sydney, and thank you for the invitation to speak. So I'm going to give the really interesting part of the talk, which is about exercise tests. So I'm glad that we did the other bits first because it's much more interesting, much more relevant. So hands up, how many people have actually had an exercise test here? Okay, so you know what an exercise test is. Basically, it's where you run on, are my slides coming up? Running on either a treadmill or cycling on a bike. And there are reasons to do an exercise test. It's sort of like, it's also called a stress test, so we're stressing the system and seeing what reserve capacity the cardio and pulmonary systems have. Most stress tests that we do test dynamic exercise. That's sort of involving some form of limb movement, rather than static exercise, or what we call isotonic, where there's no limb movement. And exercise tests that we put you through test both what's called an aerobic system, which is where there's oxygen available to exercising muscles, and also an anaerobic component, which is where there's an oxygen debt. As I said, it's either on a bike or on a treadmill, and there's pros and cons of either one. And basically, we prescribe a protocol that you exercise on where there's a graded increase in the workload. And for a treadmill, that's basically where the speed or the incline of the treadmill changes over time. And with a bike, there's a sort of electronic braking system that increases the resistance to pedaling. And the things we monitor are your ECG, that's the heart rhythm, your blood pressure, your oxygen saturation, and then there's some form of analysis of the gas that goes in and the gas that you breathe out during exercise, and that gives an idea of the oxygen and carbon dioxide, and that gives us an idea of the oxygen consumption and the carbon dioxide production, all of which are useful bits of information for us. So why do we ask you to do an exercise test? If you have specific symptoms related to exercise and we want to try to understand what those symptoms might correlate with, we might ask you to do that as a periodic check of your cardiopulmonary reserve, and it provides some objective measures that we can track over time. We might ask you to do an exercise test before or after commencing some form of medication or doing some other type of intervention like an operation or a catheter procedure. An exercise test could theoretically be used to estimate prognosis, but I think there's no specific one parameter that we can use that would be very accurate. There are some measures that we use that might support referral for a heart transplant, for example, but beyond that, the prognostic capability of any one measure is questionable. So we get this sort of detail, lots and lots of data in an exercise test. And basically, what happens to the heart and lungs when you're doing aerobic exercise? So for one thing, your heart rate goes up. And there's a sort of steady increase in the heart rate as the workload increases. And the predicted maximum heart rate can be calculated as 220 minus your age. And there's a measure called the heart rate reserve, which is the peak heart rate minus your resting heart rate. And that can provide some useful information. And usually there's quite a rapid recovery of heart rate after exercise stops. And we can measure how quickly heart rate returns back to normal by a measure called heart rate recovery. There's an increase in the amount of ventilation or breathing that you do, and that increases as the workload increases. And there's a steeper rise in the amount of ventilation that you do as your carbon dioxide production increases. And your blood pressure also increases as you exercise. Looking at more specifically as to what happens to the sort of changes in the gases as you exercise, there's an increase in oxygen consumption, and there's a steady increase as you increase your workload. And the increase in oxygen demand is met by an increase in what we call cardiac output, and that's basically the amount of blood flow that goes around your body. And we know that cardiac output is determined by two key factors. One is by your heart rate, and the other is by what's called the stroke volume, which is the amount of blood ejected by the heart each beat. There's an increase in carbon dioxide production as you exercise. And basically, the increase in oxygen consumption and the increase in carbon dioxide production parallel each other up to a point after which carbon dioxide production is increased over and above what oxygen consumption, and that point is called the anaerobic threshold. Now, beyond the anaerobic threshold, exercise can continue and oxygen consumption can continue up to what we call the maximum oxygen consumption, or Vo2 Max. Now, to define Vo2 Max, you actually need to see a plateau in the oxygen consumption, and generally speaking, or oftentimes we don't see that plateau, but we do see what the peak oxygen consumption is. Now, before you reach peak exercise, there's a lot of important information down here, which is what this area here is called submaximal exercise. And I'll come back to that. That's an important concept. So just reiterating, so with an increasing workload, you get increasing oxygen consumption, which parallels an increased carbon dioxide production. There's increased lactic acid production in exercising muscle, but that's buffered by a complex buffering system so that you don't get acid buildup. And that buffering system produces the increased carbon dioxide. But there's a point reached where, with increasing workload, the oxygen supply to exercising muscles is outstripped by demand, and then you get what's called anaerobic metabolism, so a build-up of lactate, and then that triggers this sort of breathing or production of carbon dioxide, which exceeds the oxygen consumption. And then exercise continues until you get a peak oxygen consumption. Another important measure that we use is this Vev Co2 Slope, which is fairly consistently different in Fontan compared to otherwise healthy populations. Basically, it's where your breathing, the amount of ventilation you do, exceeds what you would expect in terms of carbon dioxide production. And that might be due to a number of reasons in Fontan. One might be due to inefficient patterns of breathing, due to non-homogeneous blood flow to the lungs, so patterns of blood flow might be different. You might have early lactate production due to reduced cardiac output during exercise, or there may be an abnormal reflex between fatiguing breathing muscles and the exercising limb muscles, which triggers abnormal breathing patterns during exercise. Now, the other thing that was asked about was oxygen saturations during exercise. And you do, even healthy populations can get a small reduction in oxygen saturation with vigorous exercise, but generally it's above sort of 92, 93%. Interestingly, very trained endurance athletes can get quite low oxygen saturations with extreme exertion. So they can be less than 90%, and that's presumably related to quite extreme oxygen extraction from the red cells. So each red cell carries oxygen around the blood, and endurance athletes to get, with training, can get more extraction of oxygen per red cell. You might have low oxygen saturations in the situation of a Fontan circulation if there's a residual shunt of blood, so or low oxygen blood to the high oxygen heart in the setting particularly of a fenestration. So what information do cardiologists want to know from the exercise test? It's the peak workload achieved, the ECG, heart rate and blood pressure response to exercise. It's that measure which I mentioned, which is the maximum or peak oxygen consumption. But more than an absolute value, we want to know the percent of predicted oxygen consumption, which depends on your age, your sex, your weight and height. We want to know what the Vev Co2 slope is. We want to have some measure of submaximal exercise capacity, and we do that by looking at what your oxygen consumption is at that anaerobic threshold point. And then we're keen to know what your oxygen saturation is with exercise. So what are typical exercise test numbers after Fontaine completion? I had a really nice slide here before my slides failed, showing sort of normal distribution of oxygen consumption. But the mean values, or the median values, are around about 60% predicted, which is what Eve mentioned before. Now, you might say, well, my God, that's terrible, but I'd make a few comments about that. The first thing I would say is the predictive power of exercise test numbers are very inconsistent. So if you look at, this was from a study called a meta-analysis, where they looked at all the sort of exercise test numbers and worked out whether they predicted bad outcomes in patients, and there's quite inconsistent findings in terms of whether any of these measures predict either death or hospitalization. The second thing I would say is, rather than one particular exercise test number, I think the trend over time is more important. Now, there are studies that show a decline in the percent predicted oxygen consumption over a period of years to decades, and that might relate to the type of pumping chamber that you have, whether it's a left ventricle or a right ventricle, or it may reflect the type of Fontan that you have. And certainly it seems like a greater decline in your oxygen consumption or predicted oxygen consumption predicts more adverse events. So why might someone with a Fontan circulation have reduced peak exercise tolerance? I think we discussed some of the issues related to the Fontan in the first talk. So there's a reduced ability to augment blood flow to the lungs because it flows there passively rather than through a pump. And that means that there's reduced ability to fill the heart, something we call preload insufficiency. There's, in some cases, reduced heart rate response to exercise, something we call chronotropic incompetence. And there's a reduced ability to augment blood flow to exercising muscles, and there may be abnormal skeletal muscle function. Then there has been documented abnormalities of lung function and distribution of lung blood flow. But I think more importantly, there can be deconditioning, so people don't train to do exercise from an early age. And there is something, certainly Fontan patients can achieve, very normal exercise parameters. So this was a study that Rachel and Eve did, looking at the exercise test results from patients in the Fontan registry, and there was a small but important proportion who developed, could get to 86, near normal exercise capacity. And I'd emphasise here also this value, which is the oxygen consumption and anaerobic threshold, a measure of submaximal exercise, which was very much in the normal range. And I think that this idea that submaximal exercise capacity is better preserved in Fontan patients than peak exercise capacity is an interesting one, or an interesting paradigm to take away. And what you see here is this study which looked at heart rate and also oxygen consumption at submaximal levels of exercise. So at lower than peak exercise, heart rate and also oxygen consumption was quite in the normal range. So what that says is that patients with a Fontan circulation, when they're exercising at submaximal levels, they do that, quite efficiently. Sometimes more efficiently than people with without a Fontan circulation. And that might relate, or these authors of this paper speculated that related to improved efficiency of oxygen extraction from red blood cells. And this study also, lots of data here, but I just wanted to take home, the take-home point is that the oxygen consumption and anaerobic threshold was much better preserved in this large group of Fontan patients than the peak exercise. So again, I think submaximal exercise should be something that we focus on. And how do you do that? Well, it's just increasing habitual levels of physical activity. And that's where Fontan patients might have an advantage, just increasing involvement in recreational sports, physical activity, and sort of play for children. What we know is that even for the general population, levels of physical activity in early childhood are highly correlated with parental physical activity levels. And physical activity levels in early childhood are highly correlated with physical activity levels in adult life. And the strongest predictor of lower exercise capacity in adult life in Fontan patients is lower exercise capacity in early life. So I think all these messages tell me that it's very important to be active from an early age. So thank you very much.